Thank you for joining me for Chapter 3 of our pathology course for this semester. So we're going to get started with our respiratory system here in this chapter. Our chapter objectives are to locate the placement of our different chest tubes and catheters. So we're going to be identifying where we can find the endotracheal tube, central venous catheter, Schwann-Ganz catheter, and transvenous cardiac pacemaker. We're going to recognize the most common complications involved with improper placement of any of those objects. We're also going to classify the more common diseases in terms of how they're going to attenuate our x-rays and how they are going to appear on the images. We're going to explain the changes in technical factors that are required to obtain optimal image quality for patients that have pathologic conditions, and define and describe all bold-faced terms in the chapter. You'll also describe the physiology of the respiratory system and identify anatomic structures on both diagrams and radiographs of the respiratory system, as well as differentiate the more common pathologic conditions that can affect the respiratory system and have radiographic appearances or manifestations. So first of all, we're going to start with the physiology of the respiratory system. So the respiratory system is kind of a complex system. We know that the function of it is basically to put oxygen into our bloodstream, to oxygenate our cells, and to remove carbon dioxide from the bloodstream after it has been depleted of oxygen, and that oxygen has been replaced in the bloodstream with the waste carbon dioxide. So the area that we're going to look at to start with here in the respiratory system is going to be the upper respiratory system. That is going to include our naso and oropharynx. And then as we get towards our trachea area, that's when we move to the lower respiratory system. So from the trachea down, that's considered lower respiratory system. We're going to follow that trachea down to where it bifurcates into two main stem bronchi. That area of bifurcation is the hilum, also known as the carina. You see on the right lung here, we have 3 lobes, and it's very important to note that that main stem bronchi of the right lung is very much more vertical than the one of the left lung. The left lung only has those 2 lobes to feed, and so it is coming out at a slightly more horizontal orientation. That's going to be important when we're looking for misplaced endotracheal tubes or pathologies such as aspiration and things like that. At the end of these main stem bronchi, they're going to bifurcate into smaller and smaller bronchi until they finally get down to the tertiary bronchi that feed the alveoli. So if we zoom in on the alveoli here, you see these very small stems of the bronchial tubes, and they are going to feed into these sacs that are called alveoli. So the alveoli themselves are very thin membraned, and they are going to articulate or touch the vasculature that's coming from one side, an arterial vessel, so providing oxygen to one side, and the other side a venous vessel, removing that carbon dioxide. So as that blood flows past the alveoli, there's going to be a gas exchange where we have the depleted deoxygenated blood in the venous system coming by our alveoli here. That's going to absorb the carbon dioxide across that thin membrane, and then it is going to attach the oxygen to the hemoglobin on the other side, and then it will take off being fully oxygenated blood to return to circulation. So the other thing that we see when we look at the lungs here, the lungs really operate, or the respiratory function really operates off of a potential different system. So we might think about it as breathing in, but what's really happening during respiration is the first thing that happens is the diaphragm is going to drop. And when the diaphragm drops, the whole lungs, including the alveoli, start to expand. And as they expand, the pressure inside of those lungs has a significant decrease. And with that decreased pressure, the pressure outside of the person is going to be higher than the pressure inside the lung, and so air is going to rush in. So then when the patient goes through expiration, their diaphragm is going to move up. That is going to increase the pressure within the lungs until that pressure inside the lungs is higher than the pressure in the atmosphere outside the patient, and so that's when they're going to expire. So that's your respiratory physiology of how the lungs are actually working. A little bit more about the anatomy. Each of the lungs are covered with a double layer membrane called pleura. The membrane that is closest to the lungs would be called visceral pleura because viscera refers to the organ. Then there's a small amount of serous fluid in between the visceral pleura and the outer layer of pleura, which is called the parietal pleura. And because of that little bit of serous fluid, it's going to produce kind of a tension area between the two, so that when one expands, the other follows. A lot of times when you see pathology, there's a disruption between the two pleura, and fluid might collect in there or air might collect in there, and then the internal component is no longer following the external component, and so you will see what is something looks more like a collapsed lung, and it's really because there's something disrupting that tension between the two layers of pleura. Now, the rate of respiration is going to be controlled in the brain, and it's at the brainstem. This is why a lot of people that have had very traumatic brain injuries and may be considered, in general, brain dead might still be breathing, because it's that reptilian area of our brain that is at the very base of the brain in the medulla that's responsible for respirations. So that medulla is going to control respirations by basically having nervous responses that cause changes in that diaphragm movement, which would then result in changes in our breathing. So the medulla, the nervous system, is going to detect changes, elevations in carbon dioxide, and when it sees that carbon dioxide elevate, that's when it's going to trigger increased depth of respiration and increased frequency of respiration. And then the last thing I wanted to talk about here is actually kind of that upper and the proximal lower respiratory tract. So one important component of the trachea and the upper respiratory and lower respiratory tract is that it's going to have a layer of cilia. And cilia are those cells that kind of look like little grass waving in the wind. And the cilia are helpful in that when the patient breathes in and the air moves down into the trachea, the moisture and the cilia are going to kind of dampen that air and make it more hospitable, or make it more prepared to go into the lungs. The other thing it does is act like little finger-like projections, so that if there's debris that is breathed in, the cilia should catch that and push it back up the respiratory tract to either be coughed up or swallowed. So that's another important function of the respiratory physiology. Now, some of the internal devices that we're going to look at and check their placement and learn how to find exactly where we should see them placed on our x-rays these are going to include the endotracheal tube, which is going to be for breathing, the central venous catheter, which is going to be inserted into a vein and then entered right to the right atrium of the heart, and a Swan's gap catheter, as well as a transvenous cardiac pacemaker. So as we know, you guys are going to be called a lot to verify placement of endotracheal tubes. That's going to be a very important part of your job and essential to patient care. So it's estimated about 10 to 20% of endotracheal tube placements are not in the proper location on the first attempt. So having them evaluated by chest radiograph is going to be essential in determining whether they're in the right location. So what we're looking for chest tube placement with the patient's head in a neutral position is that we find the carina right here, and we're looking for about 2 to 5 centimeters superior to that carina. The most common issue that may be seen is either it is not advanced far enough, and so the tip would be superior up here in the upper respiratory tract, and in that particular case, most of the time air will be going into both the stomach and the lungs, or the stomach only. That can cause the patient to become bloated and vomit, and actually aspirate vomit and cause aspiration pneumonia and things like that. So that's a very significant issue. The other issue that can often occur is that it gets advanced too far. And usually if it gets advanced too far, it's going to go into the right side, because that again was the more vertical of the two main stem bronchi. So it's more of a natural placement for it. So if it gets advanced down into that right side, what will happen is that there'll be too much oxygenation or aeration here, overexpanding this lung, and not enough over here on the left. And over time, with that decreased pressure internally in that lung can kind of fold over on itself and cause atelectasis. So proper endotracheal tube placement is essential. And frequent checks are often common to make sure that the mechanical movement of the respirator, things like that, are not affecting that placement over time. Okay. Another thing that we're often looking for is the central venous line placement. So the central venous line placement is typically started from the subclavian or a more distal axillary or brachial vein. So our subclavian vein really runs right under our clavicle here, and then it dumps into our brachiocephalic vein on the right, and then that brachiocephalic vein feeds into the superior vena cava, which goes into the right atria. So the purpose of these central venous catheter placements, they can be used for a number of different reasons. One can be used to quickly administer fluids, drugs, hyperalimentation for feedings, a number of different things that way. Another thing is they can have a pressure detector, and it can be really useful in detecting pressures in the central venous system. So the idea here is they start in these veins, the subclavian or distal to that, advance that catheter through the subclavian into the brachiocephalic, and it either stops the catheter at that communication of the subclavian and brachiocephalic, or at the location of the superior vena cava. If it goes distal to that, if it moves into the right atria of the heart, that can often cause atrial fibrillations and issues that way. If for some reason that catheter, as we're coming through the clavicular area, that catheter can sometimes catch on the jugular vein and go up the neck, as you're seeing in this example, and that would be an improper placement of that central venous catheter. So we're really looking for it coming along that subclavian, going right into the brachiocephalic, and stopping there at the brachiocephalic superior vena cava junction, or in the superior vena cava, but before it enters the right atria. So, like we talked about, usually the endotracheal tube device, usually we want it about 5 to 7 centimeters above the carina. With movement, it can be within about 2, but we're really looking for that 5 centimeters. It's about 2 inches superior to the carina. Low placement can enter it into the right main stem bronchi, leading to atelectasis of the left. High placement will cause air to enter the stomach, so you'll see a large stomach bubble. Central venous catheter placements, the tip of the catheter should be in or just superior to the superior vena cava. The complications often seen is that internal jugular placement, or if it's advanced the wrong way, right atrial placements if it's advanced too far, and a pneumothorax if they somehow advance the catheter into a lung. Swan-Ganz catheter, these are entered right or left main stem pulmonary artery, and they're seen radiographically within the borders of the mediastinum. So remember, our pulmonary artery is the artery that is exiting the lungs. And so if we were to review quickly the circulation in our heart and lungs, we have our heart, we have our 4 chambers. right atria, right ventricle, left atria, left ventricle. Superior vena cava and inferior vena cava dump into our right atria. Our right atria contracts and it pushes blood into the left atria via the tricuspid valve. The left atria contracts and it's going to push blood out the pulmonary artery, because artery is leaving the heart, and that blood is going to be deoxygenated and delivered to the lungs. In the lungs, that blood's going to get oxygenated and it's going to return to the left atria through pulmonary veins, and it'll go from left atria to left ventricle and then out the left outflow tract to the aorta to be dispersed through the body. So with remembering that, the Swan-Ganz catheter is going to be entered into through one of these distal access veins. It could be on the right or the left side, have to go to the superior vena cava, the right atria, the right ventricle, out into the pulmonary arteries and be placed there. And this is often looking for pressures of the pulmonary arteries. So it would have a detector to provide those pressures for evaluation. The challenge with this is if it's advanced too far into the up those pulmonary arteries to where it enters the lung itself, then it can cause a pulmonary infarction. Then there's the transvenous cardiac pacemaker, and the correct placement of this pacemaker is to get the tip of the electrode at the apex of the right ventricle. So what they'll typically do is insert it in the skin line up here, and then they'll run the electrodes down here, and what we're looking for is these radio opaque metal tips in the apex of this right ventricle right there. Okay, so here we see a Swan-Ganz catheter insertion, and if you're following the line here, you see that it has been advanced from probably the jugular vein down into the superior vena cava, into the right atrium, the right ventricle, and then they'll have a balloon around this catheter that will basically be picked up in the blood flow like a balloon in the stream of water, and it will be then carried out to the pulmonary outflow tract and into the pulmonary vein. So this would be proper placement of the Swan-Ganz catheter. Now, if we go on this patient here, you see they probably came down the same area. They're into the right atrium, into the right ventricle, and then as they come up, they go out the pulmonary, it looks like the left pulmonary artery, and it appears that they have advanced it too far, and it would have occluded one of those vessels, and that occlusion is going to result in an infarct or a death of that lung tissue here around the area. So when you see this wedge-shaped appearance with the Swan-Ganz catheter, it's probably been advanced too far and obstructed the blood flow. So in this particular case, they would need to pull back on that catheter, and then they would need to treat this with heparinization or whatever they choose to do. Now here on our next image, this is a depiction that we see here of the pacemaker. Now there's going to be different types of pacemakers. One might have just one single electrode where you'd see the pacemaker. Here you see the advancing wires, and that single electrode would go to the right apex. Now because the heart is kind of rotated to the patient's side, even though you're in the right ventricular apex, it's going to be to the left of the spine. Now this one has more than one channel, so depending on the patient's need and what kind of arrhythmia they have, they'll determine which type of pacemaker they're going to insert. And so sometimes it can have multiple electrodes, which this one does. So you see these two larger electrodes. We have one going to that right ventricular apex. The other is going to go, it looks like maybe to the right atria. And then they have a third one in this particular case that's going down through the coronary artery. And so those electrodes are going to help that heart keep time and zap it with the pacemaker when it becomes out of rhythm. So now we're going to start to take a look at some of our disease processes of the respiratory system. So we're going to look at congenital and hereditary diseases. Now, you might think these are the same things, congenital and hereditary, but there is a slight difference. Congenital would refer to anything that somebody was born with. So it could be something like a club foot. It could be something like a heart defect. So congenital is something you're born with, but it's not necessarily associated with a genetic malformation. Whereas hereditary disease, that is linked to your genes. So this would be something like hereditary disease might be something like trisomy 21, or in this case, cystic fibrosis, where there's a gene that is abnormal and resulting in abnormal functions. Now, hyaline membrane disease is a little bit less understood, I think, but it would be considered more congenital, as in the baby is born with it, but it is not genetically linked, so it would not be hereditary. So hopefully you can kind of get the little subtle differences between those two. So when we talk about cystic fibrosis, this is one of the more common genetically linked respiratory diseases, especially in white children. It affects chromosome number 7, and because of the chromosome number 7, it does not process chloride in the body properly. So because of that chromosome defect, the proteins and different enzymes aren't produced to process chloride. And so what ends up happening is chloride is essential for the breakdown of mucus. And without that, you end up having a buildup of mucus, which can cause some really significant challenges. So mucus is going to build up anywhere and get really thick and even hard and oftentimes infected in all over the body wherever there is an exocrine gland. So we don't even realize all the places that we produce mucus at until you see somebody with cystic fibrosis. But some of the common places to produce mucus would be, of course, in our respiratory tract, also in our pancreas, also in our intestines. And so all of those places are going to be significantly affected by cystic fibrosis, because rather than functioning, producing some mucus, passing that mucus along, they're really going to get congested with mucus. And we know when mucus is sitting in a hot, moist environment, such as the respiratory system, it's really high probability that you're going to end up getting infection. And so the cystic fibrosis is caused by the gene, results in mucus buildup. The mucus buildup results in infection, and then the infection can result in like fibrosis or scarring of these organs and tissues. So it's one of the earliest places you can see cystic fibrosis in a patient that you don't know has it is actually an appearance change in the pancreas. So some of the things that are going to be really common with cystic fibrosis is the buildup of that mucus in the lungs and infection in the lungs and repetitive bouts of bacterial infection. That repetitive bouts can result in scar tissue and then just infections getting out of control, which can lead to morbidity and mortality. In the intestinal system, the buildup of mucus and the hardening of that mucus can actually block the intestines and result in bowel perforations. It can also obstruct the pancreas, which results in limited production or secretion of some of the enzymes that are important in breaking down fats and proteins. And so digestion will be compromised. If the bowel gets obstructed, bowel movements can be compromised. If it ruptures, then they can have peritonitis. So it's a very significant disease. It can be treated a number of different ways, but there's different drugs that are supposed to help break down the DNA of bacteria. So we know that the bacteria is going to get stuck in there. So by taking certain drugs, they can kind of break down that bacteria so it doesn't cause a significant infection. They can do some physical therapy type approaches where they're basically doing cupping and different things on the thoracic area to loosen up that mucus and help them cough it up. And then other drug therapies, and they're doing a lot of research about gene therapy and different things for this now. So most of the time, cystic fibrosis causes death because of the lung issues it's associated with. So here's an image of what cystic fibrosis is really gonna kind of look like, because you can imagine the mucus is going to build up in the respiratory tract. You'll see these infiltrates throughout the lung, these patchy radio-opaque areas, pretty diffuse over the lungs there. And then when they get an infection, of course, that's going to make them more significant. The next congenital disease we were going to talk about is the hyaline membrane disease, and this is also known as idiopathic respiratory distress syndrome, or IRDS. So interestingly enough, this isn't necessarily something that the baby is born with, but it's something that shows up in the first 6 hours of life. It's usually going to affect premature babies or newborns that are born to a diabetic mother or through C-section. And the issue that they usually, or what they suspect is happening here, is that it's, again, not genetic, but it's immaturity is resulting in a lack of the surfactant material in the lungs. And remember how I said there was a little serous fluid between the visceral and the parietal pleura? That serous fluid is known as surfactant. And so if that surfactant is missing, then that tension between the two pleural linings is not going to keep them expanded, and they can cause atelectasis, or kind of a collapses of the lungs. And so that would result in significant respiratory distress, or IRDS. So here's an example of one of the things you see with IRDS. They call this the bronchial sign. And so you're seeing these air-filled bronchioles against these kind of radio-opaque lungs. And what's happening is the little alveoli in the lungs, they're not staying expanded. We're seeing atelectasis throughout these lungs. And because of that, the air is going into the bronchi, but it's not being exchanged at the alveoli level. So those collapsed alveoli are increasing attenuation, causing that radio-opaque or more radio-opaque appearance, and that's making the bronchial tree stand out more. And so this would be a finding of IRDS in a newborn child. So if we look at just kind of a summary here of cystic fibrosis versus hyaline membrane disease, or IRDS. Cystic fibrosis, that's genetic. It's because of a chromosomal defect. Hyaline membrane disease, that is idiopathic. It's usually associated with prematurity and ineffectual surfactant function. So cystic fibrosis, it's in the bronchi. It's located anywhere that we see an exocrine gland or any area that produces mucus. Hyaline membrane disease results in the collapse of the alveoli. Because they collapse, it will give a minute granular densities or kind of graininess on the image of the lungs. The lungs will have demonstrate some atelectasis, and that's where you see that air bronchiogram, where you actually see the air of the bronchi standing out rather than being more radio-opaque than the rest of the lungs. With the cystic fibrosis, we're looking to see that hyperinflation because they're having trouble expressing their air, and then irregular thickening throughout the lungs. Okay, now we're going to talk about inflammatory disorders of the upper respiratory system. So with inflammatory disorders, obviously we have something causing an inflammation, and so really review back to your inflammation discussions in the last couple weeks, where anytime the body sees an antigen or something like that, it can have that inflammatory response. It's going to increase the blood flow to the area. It's going to increase the white blood cells to the area, and it's going to try and address that. As it tries to address that that antigen through inflammation, what it can result in is, because the increase of blood flow and the increase of white blood cells, it can result in a lot of swelling. And that's really what is going to happen here with croup and epiglottitis. So with croup is primarily caused by a viral infection, which results in that being the antigen. It usually appears in young children that have that very prominent croupy, barky cough. And that barky cough is caused by a localized area of obstructive swelling in the trachea, just inferior to the epiglottis. So we can see that where the trachea should typically, be a relatively straight tube, what we will often see is that because of swelling in that trachea and around that trachea, we'll see a narrowing of that tube. Then when the child coughs and tries to, express air, it will make that barking sound. So here's an example where you see kind of a narrowing of the area. It's definitely below the epiglottis. That would be up here. So it being subepiglottic would indicate that there's some sort of narrowing, and most likely it's associated with a virus. Here again, you see a very significant open trachea, and so you can see how much that narrowing is occurring here on this patient with pathology. Now, epiglottitis was associated with Haemophilus influenza in children, and then they have started having a vaccine for this that are given to most children, and so we've seen a big decrease in epiglottitis. So epiglottitis, that itis just tells us there's an inflammation of the epiglottis. So remember, the epiglottis is the little flap in our at the bottom of our nasopharynx that is going to either allow us to swallow or breathe. So if that flap gets really swollen, as it does with this inflammation process, it can be dangerous in that it can really completely obstruct the airway. So children that have epiglottitis have very significant thickening of the epiglottic tissue due to swelling. It can get as big as like an adult thumb, and because of that, it can completely obstruct the airway. So most children with epiglottitis will be hospitalized so they can be monitored, and if necessarily, be quickly intubated if the swelling gets that significant. So here's an example where they've taken a lateral soft tissue neck. Here is the here's the esophagus. Here is the epiglottis, and you can see that it is very enlarged, and so it is going to be obstructing. If it gets much larger, it can easily obstruct this trachea. Right now it's obstructing the esophagus, but it could easily obstruct the trachea with more swelling. So quick summary, croup, that is going to usually be caused by a viral infection, and it's tapering of the subepiglottic area of the trachea. Epiglottitis, that again, it's also usually caused by a virus, but it's going to be in the supra or epiglottis area specifically. Usually croup has milder treatment where it can be treated with steam, a mist tint, oxygen. It's usually not going to close up that trachea completely, whereas with epiglottitis, usually they'll be hospitalized to be monitored in case intubation is necessary. Now we're going to look at inflammation disorders of the lower respiratory tract. So again, all of these are going to have something that caused the inflammation. So there's going to be some antigen involved. We can have viral or bacterial pneumonia. That would be the antigen. Anthrax would be the antigen. An abscess would be the antigen, where the abscess is coming from a major infection. Tuberculosis, the tubercles of tuberculosis would be the antigen. Pulmonary mycosis, the chemicals would be an antigen, and then RSV would also be a viral antigen. And acute respiratory syndrome could be caused by a number of different things as the antigen. We're going to talk about pneumonia. So pneumonia is going to be one of the most common infections or inflammation processes in the respiratory tract that we're going to see. So pneumonia can be caused by a variety of organisms. Typically, they're going to be bacterial or viral in nature. Pneumonia is going to produce 3 different radiographic patterns depending on their cause. So the first pneumonia is going to be considered alveolar pneumonia or airspace pneumonia. And in this case, the infection due to the bacteria is typically going to replace the air inside the alveolar sac with exudate, or dead white cells basically. And because that air is being replaced with exudate, the area is going to appear more radio-opaque because it's going to have a higher density or be an additive pathology. So in alveolar pneumonia, what usually happens is that the infection is spread from one alveolar sac to the next, to the next, to the next. So it's going to infect the area around it through direct extension. So because of that, it can affect the segments of entire lobes. And if it does affect the whole segment of the entire lobe, the lung field is basically going to be replaced with a radio-opaque pattern. And yet the bronchi, the main stem and the tertiary bronchi, are not going to be affected. So they're going to continue to fill with air. And because we get this radio-opaque background of the lungs and an air-filled trachea bronchi, we actually see what we call the air bronchogram sign, where it looks like we have almost like a negative contrast in the trachea and bronchium, and that's just because we're changing the background to it, where the alveoli are being replaced by exudate. The next type of pneumonia would be bronchopneumonia. Now, this kind of terminology tells us exactly where this is going to be at. So this really is going to originate in the bronchi, and then it can spread to the lungs, down the bronchi and into the lungs. Now, because this is going to affect the bronchi more, we're not going to end up getting that air bronchia sign because they're going to be as sick or sicker than the lungs themselves. The cause of this is typically a staph infection, and so we end up seeing that inflammatory process in the bronchi as well as where it goes into the lungs, or where it extends into the lungs. This will form small patches of consolidation, which just means density or radiopacity at the affected areas. Now, because breathing is going to be affected here, because the bronchi are inflamed and it's not going to be able to transition as much air through the airway, we're going to have limited expansion of the affected regions of the lungs, and therefore it can cause atelectasis, or that folding or the collapse of one area of lung. Then we come to interstitial pneumonia. So with interstitial pneumonia, this is going to affect the walls or the interstitium between the alveoli. This is typically going to be viral or mycoplasmal, and it's going to involve the walls or the lining of the alveoli and the supporting structures. And because of this, that interstitial area, and if we look at the term interstitial, that would be in between the tissue. So if we look at that interstitial area in between the main tissue of the alveoli, we're going to see thickening and even some small nodular densities form there. If this isn't treated effectively, then that thickened inflamed area of the interstitium can actually become fibrotic or scar tissue. And at that point, it may become what we call honeycomb lung. That can be identified on CT, where the lung starts to look like a honeycomb, where the walls of the honeycomb would be due to areas of scar tissue or made up of areas of scar tissue. Now, all these three types of pneumonia are typically going to be treated with heavy-duty antibiotics, and sometimes that patient will have to be hospitalized and on those through IV, and then breathing treatments and other sort of respiratory treatments that would support that healing. Now, another type of pneumonia is aspiration pneumonia. So this is when you aspirate something. So we know when we swallow, it's supposed to go down into our esophagus and stomach, and we shouldn't be introducing foods or liquids into our trachea. But due to some neuromuscular abnormalities, so maybe where your neural system is not communicating as well with your muscular system, it can affect the efficiency of swallowing. So things like Parkinson's disease or other things, multiple sclerosis, things like that affect our connections between our nervous system and our muscular system can affect our swallowing ability. And because of that, we can end up accidentally aspirating our foods or fluids into our lungs. Now, because of the setup of our bronchial tree, we know that our right mainstem bronchi is more vertical than our left. And because of that, that is typically going to be the more direct route. And we're going to typically see a little bit more aspiration pneumonia in the right lung than the left. The other thing that can cause this would be esophageal obstruction or diverticuli of the esophagus, where again we get that communication and basically it goes down the wrong tube. Now, lots of patients that have aspiration pneumonia are in very critical condition before they even get the pneumonia. And so we're going to see most aspiration pneumonia set in a dependent area, which would be if the patient is hospitalized, that's going to be in their posterior aspect of the bottom of their lungs because they're sitting and laying down. And so the fluid is going to collect there, and that's where we're going to recognize most of this pneumonia. The other thing with aspiration pneumonia, it's going to be treated again with heavy-duty antibiotics and treatments that way. So here's an example of alveolar pneumonia here. So this is bronchopneumonia. This one is bronchopneumonia, and we can tell the difference between that and alveolar or interstitial pneumonia because we don't see the bronchiogram sign where we'd actually have a more radiolucent sign showing the trachea and the mainstem bronchi. So here we can tell that it's probably been inflammation in that bronchus traveling due to gravity down into the alveoli, and so we have equal illness basically of our consolidation here in the alveoli as well as in our bronchi. If my bronchi were healthy and my alveoli were sick, then I would have a full bronchi not able to empty as well into the consolidated alveoli, and therefore we'd see that bronchogram sign. Here's a CT showing pneumonia, and you can see that this patient is probably supine or probably bedridden because you're seeing this pneumonia can really consolidate towards the posterior aspect of the lung like you would expect from a patient that is non-mobile. The next type of infection we're going to talk about of the lung is anthrax. So anthrax is caused by the Bacillus anthracis, and this is a particularly dangerous and resilient Antigen. So anthrax can actually live in the soil, in the ground, for long periods of time with no host. And what we found in the United States was that they really stopped seeing exposures to anthrax in the 70s and didn't see any exposures to it until 2001 when it was used in some biologic terrorist efforts after 9/11. So anthrax can be easily transmitted and is highly fatal, especially if it's breathed into our respiratory tract. Now, it can be we can be exposed to it in a number of different ways, including the respiratory tract. The first way is cutaneous. So if you'd had a cut or an opening in your skin and you were exposed to an animal or feces or dirt that had anthrax in it, then you could be exposed cutaneously. This is going to be the most common type, and it's more common in people that work a lot with animals or hides or things like that. The second type is probably the most dangerous, and this is in the inhalation type. So this would come from inhaling the anthrax or the Bacillus anthracis into the lungs, and without fatal, or usually it's going to be fatal if you do not get prompt treatment. So what happens is the anthrax comes in, it acts as an antigen and causes cellular edema or cellular swelling of the lungs, and because of that, the cells get so swollen that they lose their function. And so what starts out as feeling just a little bit unwell can quickly lead to coma or death in 75% of those exposed. The third type is going to be gastrointestinal, and this is when anthrax is ingested, and usually that's by infected meat. And this will cause intestinal inflammation, which can be treated, but treatments are not always successful. So anthrax is going to be very dangerous. If you look at the terrorist attacks that they used anthrax for, they were delivering it in a fine powder, promoting the idea that it would be inhaled, which would be the most dangerous type. Next is lung abscesses, and I know from your videos and review of different pathologic processes, abscesses I really like to think about as occurring when an infection or inflammation gets out of control. So the body has this great way of recognizing that it's losing the fight. So if I have a simple infection process, I know that I'm going to have, my vascular system is going to become more permeable, and I'm going to, bring more fluids and more plasma and more white blood cells to the area, and they're going to attack and hopefully take care of that antigen. Now, if that attack is unsuccessful, the body is very smart in recognizing that it better get this area contained before it spreads to other places. And so what it will do is kind of encapsulate this area and then send in lots of blood supply with lots of white blood cells to try and attack the area before it spreads. So with lung abscesses, what we often see with lung as well as any other abscess is that the abscess will result in a necrotic area of tissue where the antigen has affected this tissue, the tissue has died. And when tissue dies, it kind of becomes necrotic, it can become fluid-like, and then it can also release air. And so those are some of the things that we're going to be looking for in a lung abscess. So the lung abscess is going to be necrotic area of pulmonary parenchyma, meaning the alveolar areas, and usually it's going to contain a purulent or pus-like material, and that pus really comes from the death of the white blood cells that are trying to attack this antigen. So as they die, they produce this white-ish type pus in the area. We're going to see a lot of blood flow around the area of the abscess because the body is still trying to treat this while it's encapsulated. The other thing that if you've ever seen, roadkill on the side of the road and you see that it becomes very puffy and full of air, when we have tissue death, that's what happens. Bacteria is going to release air, and so sometimes these abscesses can have a purulent or pus components as well as air internally. So with these, lots of times for treatments, they would have to be percutaneously drained, meaning somebody would have to introduce a needle into this, pull out all the pus they could, and then put antibiotics directly in. They can also be treated with IV antibiotics. Now, anytime you have an abscess, because of the body's immunity response, you're going to have this increase in white blood count. So your body's going to be recognizing there's a problem, knowing it needs to produce more white blood cells, and you're going to have elevations in that white blood count. You're also going to have fever, because fever is one approach of the body to try and, if it can't kill it through white blood cells, it can try and burn it out. So that's what the fever is intended to do. So you're going to have fever, white blood count, and then you might have pain and redness at the area. Now, interestingly about lung abscesses, where lots of abscesses maintain complete they are completely circumscribed or held within the abscess area. Often lung abscesses end up communicating with the bronchi, and that will allow the pus to be coughed up. And so people with lung abscesses, not only do they have the white count, the fever, the chills, they probably have very foul smelling pus-like sputum or cough. So here's an example where we see a lung abscess on a chest x-ray. So here in this region, you're seeing a large lung abscess where you see the radio opacity with this major consolidation in that region. Here on CT, the reason I mentioned here we see a well kind of circumscribed or contained area. This slight radiolucency would be an area of pustular type material, whereas this is air, and so this would be the air produced by the necrotic event of the abscess. Okay, so real quick summary of inflammation disorders of the lower respiratory system. We have the pneumococcal pneumonia or the staphylococcal pneumonia. Usually a pneumococcal pneumonia is going to affect the alveoli, whereas staphylococcal pneumonia is going to affect the bronchial tree and then extend into the airway. Viral pneumonia is usually going to affect the interstitium, so that's where it's going to build up those fibrotic areas in between alveoli. So with our pneumococcal pneumonia, or our also known as the alveolar pneumonia, we're going to see lobes and segments of radiopacity, and that will be treated with antibiotics. Staph pneumonia, that's going to, with the pneumococcal pneumonia, that's also the one that we may see the bronchogram sign with radiolucent bronchogram that you can recognize with that more radio-opaque backdrop of the inflamed alveoli. The bronchial or airway pneumonia, remember the bronchial tree is very sick and it's actually presenting that infection into the alveoli. So you'll see inflammation of the bronchial and alveoli, and so you don't get that bronchogram sign. That will also be treated with antibiotics. And then the interstitium pneumonia, that is going to cause those fibrotic scar tissue changes, and so you typically see those in the linear or reticular or honeycomb patterns. And then aspiration pneumonia, that's from breathing in something liquid or solid, and that's typically going to go to the right side more than the left because the vertical orientation of the bronchus, and it can cause patchy opacification on the areas that are affected. For those patients that are bedridden, those areas are typically going to be in the posterior aspect of the bottom of the lungs. Anthrax, like I said, can be an exposure that's very dangerous and is going to cause diffuse edema in the lungs and affect the cellular function. With this, you might recognize mediastinal widening, so the area in the middle of the chest can be wider than expected, as well as identify some pleural effusions, meaning fluid within the lung cavity without any infiltrates in the actual lungs themselves. And then lung abscesses, that would be any antigen that got in, or could have been pneumonia, could have been anthrax, but if the body didn't get it that inflammation wrapped up quickly, it might go ahead and turn into an abscess to try and prevent it from spreading. So this will typically see an encapsulated radio-opaque mass, and it can have an air fluid level from that necrotic tissue and pus settling. Okay, that brings us to tuberculosis. So tuberculosis is caused by the Mycobacterium tuberculosis. It's a rod-shaped bacterium with a protective waxy coat, and that protection, that waxy coat, really allows it to live outside of the body for a long time with no host without being destroyed. And it spreads mainly by droplets of air, so it's not going to be aerosol. It's going to be usually a droplet that you would have to breathe in. So that's why patients with tuberculosis are typically in a special pressurized room to get rid of those droplets. So tuberculosis is, usually breathed in through a droplet. Now, tuberculosis can be contained in the sputum of an infected individual, and you can get infection through their droplets, or those droplets can actually dry and become aerated, and you can become infected that way. The tuberculin itself is going to be a waxy coated substance that once it is inhaled, it will settle into the lung and it will attract an inflammatory process around it. This is going to be a good example of a granulomatous disease where it creates this granuloma. Now, if the infection is, you have minimal tuberculins, and the body's reaction is efficient, then hopefully it will simply encapsulate and prevent that tuberculin from spreading. If the person is immune compromised, which is common with somebody that maybe has AIDS or is in a weakened state for some reason, then this is going to go very differently. Also, if you have a really high level of inhaled tuberculins, then you may have the same issue, to where the tuberculin bacilli can actually fight off and damage that inflammatory process, and then it will produce a mass. Now, lots of times that mass is going to be in the upper apical region of the lungs, and so this is one of those where, for tuberculosis, a known case, sometimes they'll order a lordotic view like we see in this first image to see if there happens to be something hiding up here underneath the clavicle. Now, because if it does get out of control and the bacilli are able to basically overcome that inflammatory process, then it will start basically almost acting as an abscess. So you might see air fluid levels in these regions, and they can lead to a very significant case if not treated, such as the one on the right, where we see these areas of completely destroyed lungs filled with air fluid levels from the tuberculosis. Now, because of that, it can develop connections to the bloodstream where a blood vessel gets basically eaten away by the bacteria, and then the patient can have bloody sputum or hemoptysis. The other thing with tuberculosis, if those tuberculin bacilli are introduced to the bloodstream, then it can result in something called miliary tuberculosis, and it can travel to other organs such as the spleen, the liver, a number of different places. And if you see that occur, what you'll find is, maybe if we pretend down here in the liver that they have miliary tuberculosis, you would see these little granulomatous reactions all over the organ that's being affected. So in ultrasound, we call that the starry night appearance, because you see these little collections, almost like constellations, of granulomatous disease. And remember, granulomatous disease is basically where you have an antigen that gets encapsulated and it creates this calcified or radio-opaque appearance around it. So with tuberculosis, it's essential that you're following proper PPE guidelines to protect yourself, and that those patients are getting treated quickly and aggressively, and that you're following all your all of your PPD first step, second step, all those tests, or a quantiferin to ensure that you don't secretly have this that you could be spreading around. So summary of findings of tuberculosis. So primary tuberculosis would mean that it came in through the lungs and you're seeing it in the lungs. That's primary. So you'll often see it affected lobarly, so within the lobes, where you're going to see those tuberculins react and create the consolidations of dense and well-defined areas, sometimes with air fluid levels and even blood in the area. You can also see hilar or mediastinal lymph node enlargement. So because the inflammation is in that area of the hilum of the lungs or the mediastinum of the chest, those lymph nodes may be reacting, pulling some of those tuberculin bacilli out of the bloodstream and then processing them, which would cause the lymph nodes to become enlarged. You can see parenchymal, alveolar, hilar, or mediastinal nodes as well. And you can see damage to the pleural cavity, including pleural effusions. So the treatment with this would be a 2-drug regimen for 2 months or longer that has to be followed very rigorously, or else the tuberculins can mutate and become more and more resistant. Now, if those tuberculins get into the bloodstream and get delivered to other organs, that's when we're going to call it miliary tuberculosis. And then we can see throughout the lungs and other organs these small radio-opaque areas spread throughout the organ, as well as necrotic cavities of abscess and air fluid levels, and then fibrotic or scar tissue changes. So our next pathology we're going to talk about is pulmonary mycosis. So there's a couple different types of pulmonary mycosis because it's the umbrella term that really refers to some fungal infections of the lungs. So these fungal infections usually come from the earth. So the 2 most common types of fungal infections in North America are histoplasmosis, which is really common fungus in the Mississippi Valley, and coccidioid mycosis, sorry if I butchered that, which is going to be more common in the Southwest. So both of these are going to be, aerated fungus that can be breathed in and can affect patients. Now, most of the time, people that are exposed to fungal infections that have a normal, healthy immune system are going to clear these with no issues. These are going to be the most dangerous to people with those compromised immune systems, like somebody on chemotherapy, the very old, the very young, and then patients with things like HIV and AIDS. So histoplasmosis really has a very similar appearance to what we see with miliary tuberculosis. So we would also classify this as a granulomatous disease, where the antigen or the fungus gets in, the body can't clear it, and so basically it encapsulates it in a mass of scar tissue. So we're going to see this diffuse radiopacity throughout the lung field. The choriosis, and I'm going to say that incorrectly, so that is going to have a very similar appearance. Now, both of these could lead to few or no symptoms if they're cleared quickly, but they can, in chronic cases or somebody that's immune compromised, lead to lung abscesses, rupture the mediastinum, rupture the pleural cavity, and cause some other additional issues. The other thing is some of this can settle into our lymph nodes, and when it settles into the lymph nodes, then we can see these calcifications in the lymph nodes as well. So here we're looking at primary histoplasmosis. That means you have, like I said, more common fungus in the Mississippi Valley that you have breathed in. Some of these fungus, the body hasn't been able to clear it, and so what we often see is lower lung and hilar lymph nodes that are affected. They're going to have pulmonary infiltration with those granulomatous nodules that are going to result in radio-opaque, diffuse spots of attention. Okay. We might also see hilar lymph node or mediastinal lymph node enlargement. These may require treatment for patients, especially those that are immune compromised. Now, if that histoplasmosis is not treated or is not successfully treated, it can become chronic histoplasmosis, and this is most notably recognized in the upper lobe of the lungs, and it can be presenting as parenchymal consolidation, kind of like pneumonia of the area, as well as cavitation, where we're getting some death in necrotic tissue, and then the calcified granulomas, kind of like on the x-ray we just looked at. If you have acute coccocoidoid mycosis, this is typically going to affect the peripheral parenchymal first, and it's going to have more of a pneumonia type appearance with possibility of some granulomatous disease appearance. Usually they're not going to treat this unless you're immune compromised and they think that you're not going to clear it on yourself. If it becomes chronic, then you do still recognize it more in the peripheral parenchyma, and not only can we have that granulomatous type appearance, you can also end up with lung abscesses. If it becomes very dangerous, then it would be treated with amiferexin B. So RSV, or respiratory syncytial virus, is going to be the most common cause of bronchiolitis, with estimated that nearly all children by age 2 have experienced this at some point or another. RSV is going to attack the lower respiratory tract, resulting in necrosis of the respiratory epithelium, or that inner lining of the respiratory tract, and of the bronchi and bronchioles, and cause bronchiolitis, or inflammation of the bronchioles. So because there's going to be inflammation of those bronchioles, they're going to be producing edema and necrotic cells that can kind of obstruct that airway. It can then produce the bronchial spasm, causing almost like asthma types of spasming attacks, where the child would not be able to inhale and exhale air efficiently. And because of this disruption of the breathing process, pneumonia can occur as one of the first signs. Here's an example of a child with RSV, and one of the main things that they're going to see initially is a kind of a diffuse radiopacity throughout or enhanced lung markings. And that is going to be because of that inflammation in the bronchi and alveoli. This can lead to necrosis and ultimately a pneumothorax if the lung cannot move enough airway through there that they can't maintain the pressure within the lung. So a severe acute respiratory syndrome, that really appeared on the world stage in about 2003, where the first case appeared in China and then spread throughout from there. It is a version of the coronavirus, and the causative agent of this is kind of unknown etiology, so that's one of the factors in diagnosing this. SARS is transmitted through direct or droplet contact. Patients that get SARS can have a lot of difficulty breathing. They can require intubation and mechanical ventilation, and it has about a fatality rate of about 3%. The SARS virus can live external to the body for a number of days, and so it's important that you're practicing good protection methods if you are exposed to a patient with SARS. Most patients with SARS will have upper and lower respiratory infections that will begin with a non-productive cough and then ultimately result in hypoxemia, because the transition across that alveolar wall of oxygen is not going to be efficient because of the pathology. So RSV is going to be because of bronchial epithelial illness, and it is going to then affect the bronchi, meaning that we can't move lungs in and out of, or excuse me, move air in and out of the lungs as efficiently as possible. So it can result in hyperinflation if you're having bronchial spasms that prevent exhalation. And if you have that hyperinflation, you'll have increased interstitial markings. It can result in interstitial pneumonia, and severe cases can result in atelectasis, where if not enough air is being introduced into the lungs to keep them open, then they'll collapse on themselves, resulting in atelectasis. In this case, most of the time treatment is not necessary, but occasional hospitalization is, and treatment with ribavirin. Acute respiratory severe acute respiratory syndrome, or SARS, usually is throughout both lungs, caused by basically a family member of the coronavirus. It will result in early focal infiltrates that can progress into patchy interstitial infiltrates, and it's usually caused by or treated with bacterial or antiviral agents. And now we'll get to diffuse lung disease. So when we're talking about anything that is diffuse, I want you to pay careful attention to what diffuse means. So diffuse means without, or throughout. If something is focal, it's contained in one region, whereas something is diffuse, it's throughout the whole area. So our diffuse lung disease is not going to affect one spot, like maybe pneumonia or tuberculosis. This is when it travels throughout the whole lung field. So a few of our diffuse lung diseases that we're going to look at are ones that you guys see in clinical all the time. The first would be chronic obstructive pulmonary disease, or COPD, which includes, as a subcategory, would include emphysema. Another would be sarcoidosis, and then pneumoconiosis. So, like I mentioned, chronic obstructive pulmonary disease is an umbrella term that encompasses a number of other actual pathologies. And so, some of the conditions that it encompasses would be chronic bronchitis, emphysema, and asthma. So, emphysema Emphysema is often a result of smoking, but not always. Sometimes emphysema can occur because of other reasons. So the idea with emphysema, or what happens during emphysema, is that usually there's some sort of obstructive disorder. That could be asthma, it could be chronic bronchitis that causes excess mucus production, which will clog the small bronchioles and cause those alveoli to become more and more expanded to where they're not able to pass air as well. And so what that kind of looks like is usually our alveoli will, kind of act as kind of these deflated little balloons, right? And air comes in, fills up the balloon, and that balloon basically transfers oxygen across the capillary wall, and takes in carbon dioxide from the capillary wall, or from the venous side. And then upon expiration, that balloon gets collapsed again, and it continues to fill and empty like we see here. Well, because it's a bronchiole that is feeding into this alveoli, if somebody's producing excess mucus that gets trapped in here, oftentimes that would be from smoking, from pollutions, things like that, then that's going to get air trapped in here that can't escape. And so the balloon ends up becoming very, very full and thinned out. So because of that, what we'll see is, rather than having a thick wall balloon like we expect to have, we end up with a very thin wall alveoli. Now, when that happens, what we see is the lung field becomes very much more radiolucent than we expect, and we also see a lot of flattening at the diaphragm level, and here you can really see it. You'll note on your patients too that they have a much more barrel-shaped chest. Now, it's not always just the mucus that can obstruct these bronchi and lead to emphysema. Sometimes it can be severe asthma, where because of bronchial spasms, the bronchi will just narrow so much that it won't let the air of that alveoli out, and that can result in emphysema as well. Here's a CT exam where you can see the complete destruction of those alveoli because of long-term hyperinflation that they've basically broken down, and this patient is left with like minimal still functioning alveoli here. Asthma, like I mentioned, that's caused by bronchospasms, and so that could be in the trachea, the main stem, or the tertiary bronchi. And so it's it can either narrow where it's difficult to breathe in, but more often asthma causes difficulty for expiration. So the patient feels like they can't breathe, but really what they're um, what they're experiencing is they can't expire. So they're getting air into that lung, but they can't get it out. And so they're getting more and more their lungs are filling up more and more and over expanding because of the bronchospasms. So asthma can be effectively treated with things like corticosteroids or anything that is going to reduce the amount of inflammation as well as spasming. Sarcoidosis is a disease of unknown origin that is often identified in young adults, particularly the African American population, and the cause of it is really unknown. What we see with this is usually is found on a radiograph, a screening radiograph of somebody that's asymptomatic. And what can happen is that they are going to end up demonstrating hilar lymph node enlargement and then a diffuse parenchymal disease. Sometimes on CT, they can identify a left paratracheal node and a ground glass type of appearance on X-ray. So when we summarize the findings of this diffuse lung disease, we have chronic bronchitis. That is going to be a bronchitis I didn't really cover, but it's chronic inflammation of the bronchial tubes, and that is going to produce mucus that can then get lodged in those small tertiary bronchi. So chronic bronchitis will then often lead to emphysema, along with other things like asthma, where it's going to cause in hyperinflation of the alveolar sacs, so they can't empty completely, and they'll become like expanded balloons. So with emphysema, we're going to lose some of that lung marking appearance. They're going to become more radiolucent because of the destroyed alveola. Now, if those alveola can get very, very large and destroyed, then we see something like we looked at in the CT earlier in the PowerPoint. There's no cure for emphysema once it gets to this point. There's simply treatment for different symptoms. Now, asthma, usually caused by either allergen or stress reactions, causes spasms in the bronchi, resulting in difficulty with exhaling in particular, and that classic wheezing sound. So usually there's no evidence of acute asthma early on, but if asthma is left untreated, then it can really lead to things like emphysema because those alveolar sacs are not able to clear completely with exhalation. So treating asthma with preventative measures, either pills, steroids, or rescue inhalers can help to prevent some of the long-term effects of asthma. Ectasis means dilatation of. So usually, we didn't cover this earlier, but bronchiectasis would be dilatation of the bronchial tubes. Usually it's caused by a severe infection that necroses some of those bronchial tubes and will cause dilatation there and prevent them from functioning properly. Because of their lack of functioning, you can appreciate a coarseness or decrease in interstitial lung markings because it's not controlling as well the amount of air that's going in and out during inspiration and expiration. These, by treating the patient with vaccines before they ever get the infection that would lead to bronchiectasis, we've seen a significant decrease in the number of cases of this. Now, for the patients that have gotten bronchiectasis and it's progressed, usually you'll have notice a significant change in the basal or lower segments of the lower lobes, and they can have completely cystic replacement of the alveoli in that region. And then sarcoidosis, like I said, has no specific known etiology. It looks like that ground glass appearance or a granulomatous disease that we spoke about earlier, where we have the antigen come in, it gets encapsulated in fibrosis and becomes this radiopacity or that ground glass appearance throughout the chest. Now, pneumoconiosis is another umbrella term that's going to refer to a number of different pathologies or disease processes. And most of these diseases are going to be caused by exposures. So the three most common types are asbestosis, where a worker is improperly protected or exposed to asbestos for long periods of time. That would be common in construction situations, especially, earlier in the 40s, 50s, and so where they were using asbestos a lot to build with. The next is silicosis. This is where somebody is exposed to a lot of silicone, which is a major component in sandblasting. So people that are participating in that type of work will be more at risk for this. And then finally, anthracosis, which is the coal workers' disease, where they're being exposed to large amounts of dust with coal mining. And so these type of diseases are typically due to exposures. All of these diseases are really kind of fibrotic scar tissue type reactions to the exposures. So with asbestosis, if asbestos is left unbothered, then you might not see any issues from it. But as soon as it is destructed, it can set free loose fibers that can be breathed in, and those loose fibers in the lungs are going to cause a scar tissue type reaction. This is very similar to silicosis, where the silicone in the lungs are going to cause a fibrotic reaction or scar tissue to develop. And so here you see an example of asbestosis where those fibers have gotten into the lungs have developed fibrous tissues, and we see these long radio-opaque scar fibers. Silicosis, like I said, works similarly to where the very small, rather than being fibers, there's very small particles of silicon that are dispersed throughout the lungs, causing that fibrotic reaction and this appearance of this kind of, again, similar to sarcoidosis, it will cause this appearance of kind of a ground glass. And then similarly, here's coal workers pneumoconiosis, and you see the scar tissue developing in these linear type lines throughout the lung field. And an additional note, the coal workers pneumoconiosis, it can cause what they call black lung disease, which you've probably all heard about, because the body's never able to rid itself of those particles, and so the patient's stuck with this, meaning that there's really no treatment, only prevention of it getting worse. And lots of times this is a long-term reaction, whereas silicosis might occur more in the first 10 months of exposure. The asbestosis and the coal worker's lung, those are usually going to be longer term exposures that result in these. One additional note about the asbestosis is that it is associated with mesothelioma, which is a conversion of that disease into a malignancy that is highly aggressive in the lung area. So, summary of our findings for pneumoconiosis. First, we had the silicosis, which is usually affects most the upper lobes and the lung parenchyma. It's usually because of the small nature of the silicon distributed throughout the lungs. It's usually more diffused with multiple defined scattered nodules of pretty uniform density, similar to that ground glass appearance. For these cases, they can occur pretty rapidly upon exposure, and so to improve outcome is mostly to try and prevent any further damage. Asbestosis is going to be those long fibers that are going to settle specifically in the pleural lining, and they can calcify and produce fibrotic changes or scar tissue there. And so they're going to be identified as pleural thickening with calcified radiopacities. And then again, no real treatment, just breathe clean air and hope that it doesn't turn into mesothelioma, which would be a malignancy. And then anthracosis, that's going to be the coal miner's lungs. Again, because of the small nature of the particles, this is going to be throughout the lung, causing black lung. These will have multiple, less well-defined nodules, but still be granular, or like a granulomatous quite appearance. And again, with this, just treat the complications rather than the actual disease. Neoplasms of the respiratory tract are going to refer to any abnormal growth in that tract. Those could be benign or those could be malignant. If we look at a solitary pulmonary nodule, that is basically just a finding that we don't really know what it is. It's solitary, so there's one. It's pulmonary, so it's in the lungs, and it's a nodule or a mass. If they then biopsy that and find that it's a bronchial adenoma, this would be a glandular tumor. Remember, adenomas come from the glandular tissue. So a bronchial adenoma would be a benign bronchial tumor. Bronchiogenic carcinoma is telling us that this is a malignancy of the glandular tissue. So bronchiogenic carcinoma would be a malignancy. And then a pulmonary metastasis would be coming from somewhere else. So these are some of the common neoplasms that we can see in the chest. We're not always going to know from just our imaging which of these it is going to be. There are some indicators whether it's going to be benign or malignant based off of its imaging characteristics, but there's really not a guarantee typically unless they put a needle in it or do a biopsy, which oftentimes those biopsies are done under CT. So if we have a solitary pulmonary nodule, then this is usually just an incidental finding on a patient's screening or some other chest X-ray. Especially if the patient is under age 30, the likelihood of this being benign is very probable. As we age, the probability of it being malignant increases to where if we're at age 50 or over and you see one of these, it probably has a 50-50 chance of being malignant. If it is representing it could be representing, a benign granuloma, which would be like a granulomatous response that we've been talking about. That's really not going to go anywhere or cause any major problems other than whatever the granulomatous disease that's present is. It could be a small neoplasm, or it could be a solitary metastasis, which would mean we probably have cancer somewhere, we do have cancer somewhere else, and it's appearing now in the lung. So here's an example on a chest X-ray of a benign, solid pulmonary neoplasia. And here it is on the CT. You can see that it is pretty well circumscribed. Most of the time that something is well circumscribed like this, it would indicate that it's hopefully benign. Malignancies tend to have a little bit more invasive type appearances where they might have little extensions kind of grasping or growing into the tissue. So the circumscribed appearance of this would be a positive indicator that it may be benign. Now, a bronchial adenoma is a very low-grade malignant lesion, so that low grade means that it's not completely benign, but it's going to be a very slow growth. It appears in the younger age group than bronchiogenic carcinoma, which is going to be a much faster growth. Some of the most common symptoms of this would be hemoptysis, which would be coughing up blood, and recurring pneumonia. And this could be because of that tumor growing through the walls of vessels, causing it to bleed into itself or bleed into the bronchi, resulting in that the blood-producing cough. And then if it happened to be blocking some of the bronchi or preventing good gas exchange through that bronchial system, it could result in the accumulation of bacteria or viral components that would lead to pneumonia. And so it could cause issues that way because of kind of that taking up space or obstructing slightly the bronchi. Here's an example of a bronchial adenoma. Again, adenoma is telling us glandular tissue. Now this one you see still looks pretty well circumscribed, so you might think it's completely benign. But if they biopsy that, they would find that low-grade malignancy. You do see that it is slightly a little bit irregular. So, you know, it has some characteristics that could be concerning, but again, until they biopsy it, it's going to be hard to commit. Now, bronchiogenic carcinoma, genic would mean creating or developing. So bronchiogenic would be a carcinoma or malignancy from the glandular tissue or the epithelial tissue in that bronchi. This is the primary carcinoma of the lungs. It usually arises from the mucosa of the bronchial tree, and it's linked to smoking and other inhalations of carcinogens such as pollution, gas, industrial flames or fumes, or anything that would be irritating to that bronchial tree could cause a mutation of those cells and result in a carcinoma. The common types of bronchiogenic carcinoma, if we had to break them down, would be non-small cell and small cell, also known as oat cell. The non-small cell carcinoma makes up about 80% of all lung cancers, and this is a squamous carcinoma, which means it affects the squamous cells, which, if you remember from your basic biology classes, those are the kind of irregularly shaped lining epithelial cells that we find in different airways. It is considered an adenocarcinoma, meaning that it does have the epithelial and glandular components, and it is adenocarcinoma, is also a type of, in addition to our squamous carcinoma. And then we have the bronchiolar or the alveolar cell carcinoma, which is the least common, and that's going to affect or begin in the alveolar region of the pulmonary system. So here's an example. You can see that there's a lot of motion on this image. That motion is because this is a tomographic image. And here we can see large masses in the hilum in this region, with everything else blurred out, and then again over here indicating that there's a bronchiogenic carcinoma in this patient. Now, pulmonary metastasis means that I've had a cancer in another organ and it has metastasized to the pulmonary region. They can develop by either hematogenous or lymphatic spread, meaning that it could be delivered, blood was picked up in the liver, delivered to the heart, and then delivered to the lungs. It could be seeded basically in the lungs from where it originated at in the liver. It can also be spread through lymphatic system. So, you know, you pick up the lymphatic, maybe you have a brain tumor, and that lymphatic system picks up some of those cancerous cells and delivers it down to the lung region, and then it settles into the lung from there. Most common pulmonary metastases are from musculoskeletal sarcomas, myelomas, and carcinomas of the breast, urogenital tract, thyroid, colon. The carcinomas of the breast, esophagus, and stomach can spread to the lungs via direct contact because of their close proximity to the lungs. Those that are coming from farther away are usually going to be from hematogenic or lymphatic spread. Here's an example of a patient with multiple pulmonary metastasis, and this kind of classic for those round type focal appearances diffusely throughout the lungs. This patient has a significant metastasis. So solitary pulmonary nodule We can find it anywhere throughout the lungs, but if it's solitary, it's just one. If it has a dense or popcorn calcification, it's a good indicator that it's benign. If it has nice circumscribed rounded borders, that's a good indicator that it's benign. If it grows extremely rapidly in a month, oftentimes that means it's benign. Or if it doesn't grow at all in 18 months, that should mean it's benign. What we're really looking for to indicate that this could be a malignancy would be that doubling in size or so over 6 months to a year's period. Now, these, again, they're just basically an unknown at this point. You won't really know what it's made up of until they do a biopsy. The bronchial adenoma, that's that glandular structure of a major segment of the bronchi. It is going to have low-level malignancies. It can cause peripheral atelectasis if it's preventing airflow to a certain component of the lungs, and they'll collapse in on themselves, resulting in atelectasis. If they take up a large portion of the bronchi, then they can cause obstruction of bacteria from getting out of the lungs and result in bacterial or viral pneumonia. Then we have bronchiogenic, so this is produced in the bronchia. Carcinoma, that tells us that this is a malignancy. We'll find these in the lung parenchyma, and they are usually ill-defined. They can affect the flow of air in and out, which will obstruct the dilatation of the alveoli during inspiration, causing them to not expand as much as required, and then we'll get that collapse in on itself, resulting in atelectasis. We can also see hilar enlargement with these because it is a carcinoma. Lymph nodes are also often going to be enlarged, so it's not unusual to find that hilar area enlargement because of the lymph nodes and maybe some edema. And ultimately, if it outgrows its blood supply, it can result in cavitation of the upper lung. For this, it's going to be treated with resection, possibly radiation therapy, and possibly chemotherapy. Pulmonary metastasis, that would be throughout the whole lungs. It's going to start in one place, but it will typically spread throughout the whole lungs. And this is where we see multiple nodules. They're going to have sharp margins. They're going to show a snowstorm type appearance. And then coarsened interstitial markings. Okay, which pulmonary pathology is caused by inhalation of irritating particles? I'll let you answer that. One of the most common systemic fungal infections in North America is? And now we're going to move to our vascular diseases. So when we classify our vascular diseases, that means any disease in the pulmonary system, since that's what we're talking about today, that's going to affect either an artery, a vein, a capillary, or a venule. So the first one we're going to talk about is pulmonary embolism. The second would be septic embolism, and the third would be pulmonary arteriovenous fistula. So pulmonary embolism, an embolism is basically a blood clot that is going to wedge itself into a vessel and prevent any tissue beyond that occlusion from getting circulation or blood flow, nutrients, oxygen, and so on. So if an embolism blocks that blood flow for long enough, it will cause infarct or death of the tissue and necrosis. So the pulmonary embolism is the most common lung pathology for hospitalized patients, and it can be fatal. In about 80% of cases, it's asymptomatic. In normal, healthy adults, most of the time, they can set up collaterals, or they can their body will develop vessels to feed and drain the area without any long-term effects. But in patients that have cardiovascular disease, many times this can be basically a death sentence. It is very difficult to diagnose a pulmonary embolism based off of general x-ray. Using a CT chest with contrast is going to be the most efficient in identifying these. More than 95% of embolisms arrive from deep vein thrombosis of the lower extremities. So that would mean one of the larger veins in the legs has a blood clot. And if that blood clot breaks free, it will be transmitted up the IVC right into the heart and then through the heart into the pulmonary arteries. And that would then affect the blood flow to the lungs there. A secondary cause or another cause of pulmonary embolism could be a patient that has atrial fibrillation, where the atria of their heart is not contracting efficiently. And so the blood sits in their heart and starts to thrombus itself, or starts to become a clot because it's not moving through as it should. And so that's another cause of pulmonary embolism that can really affect patients. So this is showing a nuclear medicine study. On the top here, we see that they're getting good fill in both sides of the lungs here. We see the little heart shadow here. These are laterals. This is the PA appearance. So you're seeing that there's good perfusion throughout both lungs. But over here, we're seeing that they're getting good perfusion here on the patient's right side, but on the left side, we're getting this lack of perfusion where no heart shadow should be, indicating that there's something obstructing the flow of blood to that region. And here we see it again. Now, if we look at this particular CT, we see the pulmonary arteries coming out of the heart here and then bifurcating to go to the lungs. And we can see this displacement of contrast right in this region that would indicate a pulmonary embolism. Now, with the pulmonary embolism, before we move on to septic embolism, with the pulmonary embolism, if it clears or if that tissue is able to get blood supply from somewhere else, then the patient should be just fine. But if it doesn't, then that tissue will not receive oxygenation or nutrients, and therefore it's going to die in infarct. And then it can necrose from there. So it's a very dangerous situation for many patients that are already compromised in their health. That will take us to septic embolism. So septic embolism is basically considered a bacterial shower. So it's where there's a lot of bacteria entering the pulmonary circulation, and because there's this unusual blood flow components, it can get trapped in the lung and not be able to get out. And then that bacteria is going to start to cause different infections of the area. So if that septic or bacterial embolism gets trapped in the heart, it can cause bacterial endocarditis or inflammation of the endocardium of the heart. If it gets in the peripheral veins, then it would be causing septic thrombophlebitis. So thrombo would be thrombus, phleb would be vein, itis would be inflammation. So it would be a septic or a collection of bacteria in the vein causing a thrombus, resulting in inflammation around that thrombus. And because of that, it could prevent blood flow from getting to where it needs to get. This is going to be most common with IV drug abusers. So here's an example of a septic embolism. So they had the infection get here, wedge itself in, cause a significant infection around it, and then prevent blood flow from getting out into the peripheral vessels. And so you see areas of necrosis because the body is fighting the infection, and then you see areas of infarct and necrosis because of the lack of blood supply. Then we have something called a pulmonary atriovenous fistula. So this might take a moment to discuss, but our typical circulatory system goes from large arteries to smaller arteries yet called arterioles to eventually a capillary. And that capillary is a space where about only one red blood cell can travel through that capillary at a moment. And it's across that capillary that the blood oxygen exchange is going to occur, where oxygen is transferred from that red blood cell out into the cells, and then wastes are picked up. From that capillary, it goes directly into the venous system in a very small venule. And lots of these venules come together and they're going to create a smaller vein. And then lots of veins come together and they create a larger vein, and so on and so forth. So anytime we talk about an atriovenous fistula, rather than doing this normal breakdown from artery to arterial to capillary to venule to vein, what happens is we have a significant sized artery dumping directly into a significant sized vein. Now, this can cause an issue because my arterial blood is moving with pulsatility because it's going to be pushed through my circulation system by my heart. And then my venous side really doesn't have any pulsatility. It's just kind of reacting to pressure gradients and flowing back to my heart passively. And so when we have this kind of collide of these two very different blood flows, we can get this area of turbulence where the blood can't really go forward, it can't go backward. It's just kind of washing around there like a wash tub. Now, the other thing that's happening with this AV malformation or AV fistula is that there was no breakdown to that capillary level, so there's not going to be any way for the blood to interact with those or to bypass those cells and cause and allow perfusion into that area and the transfer of oxygenation and nutrients and picking up of the waste. So with the pulmonary atriovenous fistula, it's an abnormal vascular communication, such as this, between the pulmonary artery and a vein. Multiple pulmonary AV fistulas are not uncommon, and AV fistulas can happen across the board, really anywhere in the body. But if you have very large or multiple fistulas, they can actually result in cyanosis because too much venous blood is shunting right into the arterial circulation, and we're not getting that normal perfusion that we would expect from the normal breakdown of the arterial system. So here's a couple examples of an AV fistula where we see that the balance between the arterial and the venous supply is altered, and so you're getting this collection of blood flow in the area resulting in an increased radio opacity. So pulmonary embolism, that can most often affect the lower lobes. CT is going to be our best identifier of a pulmonary embolism. Nuclear medicine, as we looked at, can also help. And then serial images by X-ray showing progressive enlargement of an affected vessel because it's backed up can also demonstrate the possibility of a pulmonary embolism. A septic embolism, remember that is going to be from basically that bacterial shower. Those will be eventually, that clot of bacteria will be caught up in the lung periphery, and they'll result in peripheral opacities or radiopacities. And those will need to be treated significantly with antibiotics until they've broken up and killed those bacteria. And then we have the pulmonary arteriovenous fistula. This is most often in the lower lobes. It's defined by a soft tissue appearing mass where that blood is basically congested into that area. Usually this will have to be surgically removed, or it can be embolized where it's basically the blood vessel is cut off so that it's no longer having that abnormal connection. That brings us to miscellaneous lung disorders, which means we're getting towards the end. So atelectasis is one that you guys are going to see frequently. Adult respiratory distress syndrome, intrabronchial foreign bodies, mediastinal emphysema or pneumomediastinum, and subcutaneous emphysema. So atelectasis is a condition where the lung is not fully aerated, and so it collapses upon itself. So for some reason there's diminished air within the lung, and usually this is associated with some sort of mucus obstructing the bronchi. And when that mucus obstructs the bronchi, the air is not allowed to move in and out of the lung with ease as it's intended. And so because of that, if air gets trapped in the lung, it's eventually all going to be absorbed into the blood, which would reduce the pressure within that particular area of the lung and cause it to collapse on itself. Another thing that could cause would be a neoplasm or a growth that is obstructing that bronchi or a foreign body. So some examples of atelectasis here, we see lots of times they are kind of linear appearing wedges, and that would be probably an obstruction right in this general region that is preventing the air from flowing in and out, and therefore the pressures in that region are going to eventually decrease and the lung will fold in on itself. And here we see it in the PA where we see these radiopacities. So I apologize, this slide should read acute respiratory distress syndrome, so you might want to mark that out. But acute respiratory distress syndrome is really caused, it ends up being a severe, unexpected, and life-threatening occurrence. It's usually caused by a variety of different medical or surgical disorders, one of them being non-thoracic trauma. And when we have non-thoracic trauma, oftentimes we're bleeding out, and so we'll have a hypotensive event. And because of that hypotensive event, our heart starts to beat faster, we start to breathe faster, and ultimately we go into shock. Another opportunity to cause acute respiratory distress syndrome, is severe pulmonary infection, aspiration or inhalation of severe toxins and irritants, or a drug overdose. And ultimately what happens is the structure of the lung is going to completely break down, and as it breaks down, it's going to release or leak fluid into the interstitial and alveolar spaces, and that is going to cause a collection of fluid in the lungs that's going to impair respiratory function and the ability of the patient to oxygenate their blood and therefore their tissues. It can be so severe that it is life-threatening. So one of the terms that they can use to describe this is shock lung, because it usually or it's often associated with patients that are in shock. Other causes I mentioned were severe pulmonary infection, aspiration, inhalation, and drug overdose. And this is acute respiratory distress syndrome, where it looks like almost a snow, a snow globe in the lungs, and that is really from the breakdown of that lung tissue and the collection of fluids in those interstitial spaces. And so these patients are in very significant danger with the ARDS. Intrabronchial foreign bodies, you guys have probably had at least one x-ray where we're looking for a swallowed quarter, an inhaled peanut, things like that that could get into the airway. So aspiration of any solid foreign body into the tracheobronchial tree will typically, this is going to be in those that are cognitively impaired or in young children. So they go to try and swallow something. Instead, it goes into the brachial tree, and then that is going to obstruct airway to a certain portion of the lung. So usually with these, we're going to identify a radiopaque foreign body on a chest x-ray. We might, because that's going to obstruct the ability of those lungs to take in and clear that air, we might find this associated with atelectasis as well. Radiolucent foreign bodies, just because it doesn't show up on an x-ray doesn't mean it's not there. So sometimes we can have those radiolucent foreign bodies, and usually we're going to have to, the doctor's going to have to do the diagnosis of that by secondary signs from the lung that would indicate that there's complete or partial bronchial obstruction, such as significant atelectasis. Now, because of that vertical orientation of the right bronchi, the right side is going to be often more affected than the left. So here's an example where we really kind of have if you look, you can barely see the carina right here. It's difficult to identify in here that there is a foreign body, but if we look down here, we see an atelectasis occurring, and so then that would indicate that there's some sort of obstruction. Here's the actual foreign body. This patient needed a little bit more technique to get better penetration to demonstrate that, so it might need a repeat of this one, but we do find the object, we do see that it is causing some atelectasis, which could be expected. Okay, mediastinal emphysema. So emphysema would be like a collection of air. So if we're having a collection of air in the mediastinum, that would be really around the heart, around the hilum of the lungs. Usually the causes of this would be spontaneous, which would result from severe coughing, vomiting, or straining, which would rupture an alveoli, causing leakage of air outside of the lungs into that mediastinal area. It could also be caused by chest trauma, where if you had a pneumothorax, you broke open that lung and it's releasing air into the mediastinum. Finally, it could be perforation of the esophagus or tracheobronchial tree, which would introduce, those are both run straight down the mediastinum, so that could introduce air to the area, or the spread of air along fascial planes of the neck, peritoneum, and retroperitoneal space. Air can also extend peripherally and rupture into the pleural space, causing an associated pneumothorax. So the pneumothorax could come first, or the mediastinal emphysema could cause a pneumothorax. Here's an example where you see that air in the mediastinum here is actually displacing the lung, causing a little bit of compression. So we see this widening of the mediastinum, pushing those lung fields out. This patient also has an endotracheal tube, so you have to wonder if this is a complication of that. Perhaps it pierced or damaged the trachea, causing some of that air to escape into the mediastinum. Subcutaneous emphysema would be a collection of air in the subcutaneous tissue, so in the skin adipose area. It's usually identified in the tissues of the chest wall. This is usually caused by penetration or blunt injuries that disrupt the air and cause that air to leak out into the tissues. It's characterized by crepitation, or a crackling sound or sensation when you press down on the patient's skin. And here you see, external to the rib cage, we have these collections of air here. And then we have collections of air here, and here. So lots of air in very unusual spaces. Okay, so atelectasis, that's usually caused by the obstruction of a lobe or segment of the lung, causing it to collapse. It will usually have an increased density or radiopacity and appear oftentimes as plate-like streaks. Acute respiratory distress syndrome, this is basically lung structure breakdown being replaced by fluids, causing patchy, ill-defined radio opacities or consolidations across the lung field. And then we have our interbronchial foreign bodies, which you guys can all identify. Mediastinal emphysema. Emphysema is just referring to the collection of air in the mediastinum here. We just have to common sense think about what could allow air out into the mediastinum. And since we have a trachea, esophagus, heart that runs right there through the mediastinum, and then lungs lateral to the mediastinum, we know that the origin of air could be from any of those things. And then subcutaneous emphysema would be anything that would introduce air into the subcutaneous space. So that would often be, again, those lungs or infection or something else. Then we have the disorders of the pleura. So we talked about how with respiration, you have the lungs. Each lung has a visceral pleura, which is a lining around that lung, and then a parietal pleura that is a lining around the thoracic cavity. And between the two, they have a little bit of surfactant or serous fluid that maintains a tension so that when the chest expands, it pulls that lung field with it. So when we have disorders of the pleura, we're really talking about those layers of the visceral and parietal pleura of the lung. So our three disorders we're going to look at are pneumothorax, which that's where we get air in between the pleural layers. Pleural effusion, that's where we get fluid or serous material in between the layers. And then empyema, this is when we get pus in the region. So pneumothorax is the presence of air in the pleural cavity external to the actual lung. And its results is usually partial or complete collapse of the lung. So If we don't maintain that tension between the two layers of pleura, the lung will simply collapse. So oftentimes when you see a pneumothorax, you're seeing air in there. It could have escaped from the lung, or the air pressure outside of the lung in the pleural space could be compressing that lung. So some of the causes could be a rupture of the subpleurabola, where it's not maintaining that tension between the two layers anymore. It can be spontaneous event in an otherwise healthy young adult, which is typically in a young male. We would call that a spontaneous pneumothorax. Trauma that would have penetrated the lung and released that air from the lung out into the pleural space. Or it could be iatrogenic causes, and iatrogenic causes are unintentional damage caused by a medical procedure. So after a lung biopsy, if they actually penetrated that lung and it released its air, that would be an example of the iatrogenic cause. And then it could be complication from neonatal Hailey disease, like we talked about earlier in the lecture. Here's an example where we see nice lung markings here on the patient's left lung. Over here, we see a lot more radiolucency, and then we see this radiopacity here. This radiopacity represents the collapsed lung because all of the air is out of those alveoli, so it produces a much more dense appearance. And then we lose all lung markings here because it's air outside of the lung, still in the chest cavity, outside of the lung, so this would be in the inner, between the two pleura. Pleural effusion is when we have a collection of fluid in the pleural space, so between those two pleural layers. It's nonspecific and it can be caused by a lot of different things. One of the things is a congestive heart failure. So with congestive heart failure, the heart is not moving blood flow through efficiently. And because of that, it congests the lungs, meaning that it's pushing blood into the lungs. It's not necessarily allowing the venous blood to leave the lungs. And because of that, it's going to congest those lungs and it's going to possibly start leaking some of that excess fluid out into the pleural space. Another cause could be pulmonary embolism, where again, because there's an embolism to the area, you could have an infarct of that tissue. That infarct then would start leaking and present fluid into the pulmonary space. Infection, if the infection gets into that space, it can produce its own fluid. Pleurisy is just inflammation between the pleural linings, and then that can actually produce some fluid. Neoplastic disease that becomes leaky could, and connective tissue disorders can. So pleural effusion can occur as a result of abdominal diseases such as recent surgeries, ascites, and subphrenic abscesses, as well as pancreatitis as well. So here's an example of pleural effusions. So here it's kind of subtle on this PA, but you can see this radiopacity. It's not part of the spine. The spine should end here. It's not part of the heart because we see the normal heart shadow here. So it's going to be this collection of fluid. They put their patient into a left lateral decubitus. We see a little bit atelectasis here, but then you can see that fluid has settled into the curvature of the pleural space, indicating that there's a pleural effusion. Empyema, as I mentioned, is an accumulation of infected liquid or pus in the pleural space. It's usually due to a very significant infective event, and it comes from direct spread of that adjacent infection. Now, there is, usually the infection is going to be in the respiratory system, but there is a possibility of a subdiaphragmatic abscess. The liver does not have a very good barrier at the top of the liver to the diaphragm. So if you have a very sick or inflamed infected liver, sometimes it can create a subdiaphragmatic abscess that would basically transition across that diaphragm into the thorax. You can also have lung abscesses and esophageal perforation. Anything that's going to be in there to get infected and produce pus could lead to empyema of the pleural space. So here's an example of a significant event. We're seeing this whole left lateral lung filled with a radio-opaque material. If they were to biopsy or aspirate that, then they would find that it was pustular. So pneumothorax is air in the pleural cavity, pleural effusion is fluid in the pleural cavity, and empyema is pus in the pleural cavity. Now we're going to look at mediastinal masses. So the mediastinum is divided into 3 compartments, with the anterior compartment extending from the posterior sternum to the trachea and the anterior border of the heart. The middle contains the heart, the great vessels which refer to the aorta and superior and inferior vena cavas, and the central tracheobronchial tree, lymph nodes, and phrenic nerves, the nerves that trigger and control your diaphragm. And then the posterior space is the space that's behind the pericardium, with not much else there. So some of the common anterior mediastinal masses would be thymomas. This would be tumors of the thymus gland. Teratomas, these are like dermoid tumors that use germ cells. Germ cells are what's present in us as fetuses, very early fetuses, that are going to produce all of our different tissue types. So a teratoma can contain components of hair, skin, teeth, fat, all different types of tissues, because they're originating from those germ cell lines. We can also have thyroid masses that extend into the anterior mediastinal areas, lipomas, which are just masses of fat, and lymphomas, which would be lymphatic tissue growth or tumors. So here's a thymoma, which our thymus gland sits right anterior to our heart. And in infants, it's very prominent, and then as we grow, it's barely detectable in adults. And so seeing something protruding off the anterior aspect of the heart, like we see here, would be indicative of a thymoma. Middle mediastinal masses, those are going to affect the heart, the great vessels, the lymph nodes, and so on, and the bronchiogenic vessels. So things like a lymph node disorder, including lymphoma, a metastatic carcinoma that is traveling into the lymphatic system, or granulomatous processes such as, some of the sarcoidosis, the asbestosis, the tuberculosis that we talked about earlier. It can settle into the lymphatic system there in the mediastinum. And then bronchiogenic cysts can occur in the middle mediastinal area, where this would be a dilatation of the bronchi in creating a simple cyst. And then vascular abnormalities, so it could be anything that's affecting the aorta or the superior inferior vena cava. And then masses in the anterior costophrenic angle would also fall into these mediastinal mass categories. So a bronchiogenic cyst, here we can see this large cyst that is difficult to identify where it's coming from exactly, but if they were able to do more studies, they are obviously connecting it to the bronchial tree, and so identifying that is what this mass is. Okay, now posterior mediastinal masses, because we don't have a lot of tissues in that posterior mediastinum, they classify it as neurogenic tumors, which would be just tumors that are growing off of neural tissue. Neurogenic cysts, which would just be a cyst growing off of neural tissue. Aneurysms of the ascending aorta, and an aneurysm is just a dilatation. So if this is my aorta, this would be considered my ascending aorta, this would be my aortic arch, and this is my descending aorta. So aneurysms would be a dilatation of the aorta in this region. If it was going to be, I said ascending. If it's going to be in the descending aorta, we're looking down here. And what that is a bulbous dilatation of that vessel. Okay. So that's coming down that posterior area, and you could identify that, maybe make it look like a mass. And then extramedullary hematopoiesis. Hematopoiesis is the production of blood cells. So if you're having production of blood cells in an unusual area, that is something that could collect in the posterior mediastinum. So here's a neurogenic cyst. So it's simply a cyst that has a huge cyst that has developed off of from neural cells. Okay, and if you see this fluid level, you can see that this patient with this cyst also has a pleural effusion. Okay, so you can read through the summary of the findings of the mediastinal masses. And we're going to look at disorders of the diaphragm. So the diaphragm, like we talked about, is really important to our respiratory process because we don't necessarily breathe in. We have our diaphragm move down, which reduces the pressure in our lungs and causes air to rush in. So disorders of the diaphragm are really going to affect our respirations. So we can have diaphragmatic paralysis, which would be a neural issue causing the diaphragm to not function properly. We can have eventuation of the diaphragm, and then other causes of diaphragmatic elevation. So a diaphragmatic paralysis is usually caused by any process that interferes with the phrenic nerve. It's going to show up on images as elevation of one or both of the leaves of the diaphragm. So we think about the diaphragm as one singular muscle, but technically it has two sides, a right and a left. And so we can see diaphragmatic paralysis affect one or both sides. It is going to diminish lung volume significantly. If it's truly paralyzed and not moving at all, it would be incompatible with life unless the patient was put on life support. So things like trauma that would cause paralysis below the neck, things like that could result in diaphragmatic paralysis. So here's an example. This is showing just right-sided diaphragmatic paralysis. Here it appears the left side is working, moving up and down, and we would call that diaphragmatic excursion, where it's moving up and down. This one would not be excursion, would not be moving, and they're saying that the cause of that was secondary to this lung cancer, probably affecting that phrenic nerve, resulting in the reduction of function of that diaphragm. Okay, eventuation of the diaphragm is a rare congenital abnormality where one hemidiaphragm, or one half of the diaphragm, is very poorly developed and weak. And so it permits the upward movement of the abdominal contents through into the thoracic cage. So basically, because the diaphragm is so weak, it doesn't push down those abdominal contents, and it allows them to push up into the thoracic cavity. It's usually pretty asymptomatic, and it occurs more commonly on the left than the right. And here's just an example. So it's still moving, but it's weak, and it's much higher because it's not holding those abdominal contents down. Okay, other causes of diaphragm elevation would be ascites. So ascites is a collection of fluid within the abdominal peritoneum. And so because that collection of fluid is going to cause increased pressure in the abdomen, it would push the diaphragm up. Obesity would be accumulation of basically fat in that area, and that could push the diaphragm up. Pregnancy would be the accumulation of having a baby in there, pushing the diaphragm up. And any other process in which the inter-abdominal volume and pressure is increased can push that diaphragm up. I'll let you read through those. Okay, couple clicker questions. Which tumor is more likely to occur in the anterior compartment of the mediastinum? And the most common lung pathology of hospitalized patients is? And with that, we are going to go ahead and wrap this lecture up. Thank you for your patience. I know it was a long one. Hopefully this will help you, along with your reading, prepare for your quiz. Let me know if you have any questions.